All right. So next up we have Dr. Stephen Boyle. So Stephen is a consultant hematologist at the Royal Brisbane and Mater hospitals who subspecializes in CAR T therapy. He completed an overseas CAR T fellowship in London in 2022 and has led a UK national review of CAR T outcomes and has published and presented nationally and internationally in the field. He is an advisor to the pharmaceutical industry on CAR T and is undertaking a PhD at the Tay Lab in the QIMR Berghofer, aiming to bring a novel myeloma CAR T product to clinical trial in Australia. Thank you, Stephen.
All right. So I've been given the task of talking about CAR T, and particularly CAR T and infections today. So I'll just run through this over the next 15, 20 minutes, and take any questions at the end. So firstly on CAR T in general. So CAR T's found its main niche in treatment of blood cancers. So why this is, most lymphomas and leukemias are B cell in origin. Treatment with chemotherapy tends to be generally less effective at relapse for any cancer, but we see this a lot in patients with lymphoma. You treat them, they relapse, and the treatment is the lymphoma obviously is chemo resistant at relapse. So using more chemotherapy, you get a lot of diminishing returns. So the question's really been for some time, obviously not just in the blood cancer space, but across the board in oncology, could immune treatments hold the answer for these patients who are inherently chemo resistant? And we've tried a lot in the world of hematology. So checkpoint inhibitors have been trialed in lymphomas and leukemias, for some years. Really not that effective, apart from in Hodgkin's, where they have some role. Dendritic cell vaccine, other novel approaches have been tried over the last 10, 20 years with mixed success. But then early in the early to mid 2010s, we eventually sort of got CAR T up and running. So this is just a quick picture of what CAR T is, and I'll go over this next couple of slides. But basically, you have a T cell, the patient's own T cells generally. You put a CAR, so a chimeric antigen receptor, onto the T cell, and you have a CAR T cell, basically. And it's an immune therapy which bypasses all these problems of chemotherapy resistance and kills the cancer cells directly. So the potential for CAR T was first recognized. Some of you in the crowd may know who this is, especially the pediatric audience here. So this is Emily Whitehead, who is really the poster child for CAR T. One of the first patients infused with really the first patient infused with the second generation CAR Ts that we use in clinical practice nowadays. So she was diagnosed with acute lymphoblastic leukemia at the age of 5. She had some chemo, went into a 1.5-year remission, doing well at that point in time. You might think a reasonable chance for cure, but unfortunately relapsed at 2012, age 7. She then had further chemo, got a 4-month remission, and then a second relapse, and had reinduction chemo, to which she was refractory. So this is an absolutely disastrous situation. And probability of cure at this stage is very low. So her family over in the US traveled to Philadelphia to enroll her in a phase 1 trial, really kind of Hail Mary type approach to see if we could get anything that worked. And she happened to go onto this trial of CAR T therapy with this second generation CAR. This is her, well, she's 12 or 13 years on now, so she's actually 20 now, I think. Almost certainly cured, gone back to university and stepped back from the public eye a couple of years ago. And still had circulating CAR T cells 10 years on. So this really sparked the field and got everyone thinking, and sparked billions of dollars worth of investment from pharma into making these treatments work. And this product that she had has been used many, many times since, and achieved some great outcomes for adult and pediatric patients. So where we are in 2025, so we have infused well over 10,000 patients, really tens of thousands of patients now. Cure rates for the main indication we use this for, which is diffuse large B-cell lymphoma, so the most common aggressive lymphoma that we treat. Cure rates are approaching 50%. You look at the registrational trials of Axicell, which is the main product we use, about 40% in those trials. Some of the UK data, which I led, we really actually, in real world data, looks even better potentially. We're curing up to half of people. And really, without CAR T, this cohort of patients, we're looking at cure potentially of 5 to 10% at best. So this is a massive improvement. And then you've got the story in myeloma, which is an even newer story. So we don't know if we're curing anyone with myeloma. Myeloma is considered to be an incurable disease in general, but we're seeing disease-free remissions of 3 years from a single infusion in multiple relapse myeloma. So that was from the trial of the Cardigan trial of cilta-cel. And that result was not believed when it was first presented. It was data that came out of China, and then the drug was bought by Janssen and licensed and replicated. So the overall response rates were like essentially 100%, and 3-year remission from a single infusion in multiple relapse myeloma is just beyond belief. There's nothing comes close to that. So this is rapidly replacing autologous stem cell transplant for both indications. These are the CAR T products available in the US currently. I'll call them products. I'll get just talk in a minute about what that actually means. But essentially, these CAR T cells target CD19, which is a pan B cell marker for B acute lymphocytic leukemia and lymphoma, or BCMA for myeloma. And we have in Australia Tezocel, Axicel, and Brexicel now approved and funded for these indications. But for this indication for Tezocel, we don't use Tezocel for DLBCL anymore because it's not as good. We use Axicel for DLBCL, which is probably in the adult world, 90% or so of what we treat, and then Brexicel for mantle cell lymphoma as well. These are really the same product with just a small difference in manufacturing step. Liso-cel we don't have available, and we don't have the myeloma products available yet, but there is a positive recommendation from MSAC, and we expect to have it funded allegedly middle of this year. I suspect it probably middle of next year, but we will see them coming to use soon. So the CAR itself, what exactly is it? So the chimeric antigen receptor basically consists of 3 parts. This is the current second generation model that we're using. Initially, it was tried without this part in the middle through the early 2000s. It didn't really work very well. People tried all different variations, but the product that Emily Whitehead received basically looks exactly like this, and all of the currently commercial EU's products look like this. So you have essentially on the front, it's an antibody fragment, an scFv, usually from a mouse monoclonal antibody, basically, to bind to your target of choice. So CD19 on a B cell would be our main target. And then you have this co-stimulatory domain, which is what makes this a second generation CAR. So this extra part here, which amplifies the signal coming through from the outside. It's really essential for the working of the CAR. It doesn't work well without it. And then you have the CD3 zeta at the back here, which is just the back of the native T cell receptor. So you basically have the normal T cell signaling apparatus stuck on the back of your CAR. So when this CAR sees antigen on a tumor cell, or a normal B cell for that matter, it will activate, kill the cell, and go through all the process of T cell activation. So rapid proliferation, release of cytokines, more T cells to the area. And because CARs are genetically modified cells, or DNA has actually been altered, the progeny of this T cell, this CAR T cell, will be another CAR T cell. So they expand exponentially when we put them into humans. People. So that's basically the construct of the CAR. The term comes from the Greek concept of the chimera, this creature made up of many parts, and the idea is that the CAR is made up of sort of an antibody fragment in the front, really. This can be from mice, it usually is, but the most effective myeloma products actually from an alpaca, which make these impressive single-chain antibodies, which is what I'm looking at in my PhD right now. But you can use any sort of anti-human antibody of choice on the front, which is a kind of antibodies or B cell type thing on the front, and then attach it to T cell machinery at the back. So that's the idea of the chimera. You have parts of different cells really coming together. And when you put them all together, you get a cell which is a normal T cell, but there's one extra receptor on it, so a CAR T cell. So how do you get the CAR onto the cell? It's pretty straightforward. Essentially, what you do is you package it into a retrovirus or lentivirus or an HIV type virus, and what that does is it basically then you then have you take out your kind of HIV, you put in your CAR, and then you expose patient's own T cells. So all the effective products currently in use are autologous. It's the patient's own cells, and you expose them to this virus ex vivo. So you do actually, nowadays, we're getting closer and closer to the ability to be able to do this from a blood draw, but we generally put people in an apheresis machine for all of our commercial products. We take off a T cell rich leukapheresis product, and then we ship them off to pharma, they basically expose the patient's T cells in the US to this virus carrying the CAR, and then a certain proportion of the T cells will be transduced with the virus, and they'll have their DNA slightly altered. The virus just basically randomly inserts into the T cell genome and expresses a CAR on the surface. So you have CAR T cells. That's how we make the products. And just briefly, as a quick example of how sort of simple this is the normal T cell signaling, which is an incredibly complex system where you have essentially here a CD8 T cell and a tumor cell, and it looks at the tumor cell. The tumor cell has to express some kind of usually intracellular cancer type peptide as a fragment on an MHC1 molecule. The T cell then needs a second signal from this co-stimulatory domain to say, yep, this is definitely bad, go and attack and kill this cell. And then you have activation. And there's many ways that cancers can get around this by hiding co-stimulatory domains, putting inhibitory molecules on the surface, hiding MHC, etc. So a lot of ways cancer can find around the immune system, which is why when you have a cancer, obviously, you have a cancer, it's already found its way around your immune system. So by putting the CAR on the front of the T cell, you basically just say, right, I'm going to choose any antigen of choice. So let's use CD19. All B cells have got it, cancerous and otherwise. And let's just target our CAR at that. We'll stick our CAR on the T cell, and it's got its inbuilt co-stimulatory domain. It will literally just latch on, seize the cell, tries to kill it. It's much more straightforward process and much harder for cancer to get around that. So what's the catch? So there is, generally speaking, no cancer-only surface antigen. This is part of the problem, but it's also why CAR T works so well in hematological cancers and hasn't yet really got working in the solid organ space so well. B cells all express CD19, plasma cells all express BCMA, which is part of the plasma cell, the myeloma CAR T. So CAR T cells, once they get going, will basically kill all cells with the antigen on them. So anti-CD19 CAR T product, when you infuse it into a patient, it will kill all the patient's B cells, bad and otherwise. So the malignant cells as well as the normal B cells. And the anti-BCMA CAR T products for myeloma will kill all the patient's plasma cells. Now that is okay when you have a cell type that is essentially dispensable. I mean, it's good to have B cells and plasma cells, but we can live without them, especially as adults. You can't live without a brain. So if you have something like glioblastoma where you want to target your CAR to, you've got to be much more nuanced and figuring out what your actual antigen of choice is. You obviously can't have a CAR designed against all neurons, essentially. So this is really why CAR T's taken off in the hematological space. It's one of the reasons it's taken off so well, because you've got a dispensable cell type, basically. So removing parts of the immune system for long periods of time is not always a good idea. So B-cell lymphomas and leukemia patients are basically left with no B cells after CAR infusion. 6 to 9 months is typical to see some B-cell recovery. But B-cell aplasia can last much longer than that, especially in the ALL setting where we actually want longer B-cell aplasia. There's a bit of there's differences between the products, but 6 to 9 months with axi-cell and diffuse large B-cell lymphoma is typically what we see. Myeloma patients with cilta-cell, that be the most effective of the myeloma products, can be left with essentially no circulating immunoglobulins, IgG levels of essentially close to zero for months or even a year or more. So you have these problems, obviously, where you have a patient who might be in a great remission, but they are at risk for infections. And CAR T causes its own, unique toxicities as well. So this immune cell associated hematotoxicity syndrome, which is basically a transient neutropenia, which occurs after CAR T infusion as well. Which is usually transient, but for some patients, 5% or so can actually last out to months or even a year or more. So it's there are problems using these products as well. And there's also this unique short-term high-risk period after CAR infusion. So rapid CAR T expansion and cytokine release in those first few days after infusion causes essentially surge response, release of cytokines into the blood, and this we term cytokine release syndrome. There's a less well understood but very common associated condition, the immune effector cell associated neurotoxicity syndrome, or ICANS, which is this acute and transient confusional state that many patients will get as well with CAR T. Generally responds very rapidly to steroids, but can be more severe and put people in ICU. people kind of seizures and comas. So it's a concern with the products, but it's manageable for the vast majority of patients and transient. And both of these things occur, especially CRS occurs in a few days after infusion, so up to 1 to 2 days post-infusion is common. At that point in time, you've just given the patient some lymphodepletion just to clear out their own, just a bit of chemotherapy to clear out their own lymphocytes before you infuse the CAR. It helps the CAR to essentially engraft. And therefore, they're neutropenic at this point in time. So they develop fever as well, and neutropenic, and they end up on a lot of antibiotics. So the first few weeks post-CAR are high risk for infectious complications. Infection prophylaxis therefore paramount. So CRS, as I mentioned, manifests with febrile neutropenia. Most patients end up in peptides the first week or two after CAR. They're in hospital for about 2 weeks after infusion. And from day zero, we're starting prophylactic acyclovir Bactrim, which goes out to at least, I keep it going for at least 6 months or until some good T-cell recovery. Fluconazole, posaconazole, or posaconazole out to a month. So usually fluconazole, but if anyone's at any significant risk factors for IFI or previous IFI will generally use posaconazole. That's out to about a month or really until neutrophil recovery. And then monthly IVIG for all myeloma CAR. We're not currently using it in Australia off trial, but we will be soon. So they all need to be a monthly IVIG infusions. And patients remain near the hospital for a month afterwards. This is just some of my UK data here, and all I wanted to show on a slide essentially was that this is basically the treatment-related mortality at 12 months. It was 7% for 700 patients we treated in the UK. And it really is mainly infections. We worry a lot about CRS and ICANS, but the reality is if you don't relapse during lymphoma, this is the main reason people die. This is the reasons for non-relapse deaths. And as you can see, the majority of this is sepsis, pneumonia, few fungal infections, a bit of HLH, the last speaker alluded to there, and COVID. This was done during the middle of COVID in the UK, so you expect a lot of that, but really it is mainly infectious deaths that we see, and this is what we all worry about. The different pattern of infections to allogeneic bone marrow transplant. So it's an autologous product, no GVHD, no requirement for long-term immunosuppression, and as much less CMV and invasive fungal infections, mainly bacterial and respiratory viruses we see. So last couple of minutes, I'll just go through a couple of cases. So this is both of these again were actually treated back in the UK. I need to make some more slides of some of the ones I've treated here, but both fairly interesting cases. This first chap's a mantle cell lymphoma, a very fit guy, semi-retired, tennis playing, 69-year-old. So he basically came in, he had relapsed mantle cell lymphoma, came over from Ireland, and he was treated with captogene autoleucel, so Brexucel, which is a CD19 targeting CAR T treatment. He developed a pretty typical sort of picture we see. So day 5, he had a fever of 38.1. That's actually a bit later than normal for CRS, but not out of the realms of what we see. Got tocilizumab, which is an IL-6 receptor blocker, which we use routinely for CRS. So we use this alongside steroids quite early. There was concerns initially when we first started doing CAR T that giving a lot of steroid early on would kill off the CAR Ts, but we know now that that's not the case. They're really robust, to be honest with you. So you can give steroid early for CRS and not have to worry too much. See about tocilizumab, had a septic screen done, started meropenem, who's penicillin allergic. Next day, got some CRS, had some more toci, and we started dexamethasone now. So we're doing 10 milligram BD dexamethasone. Got started on some vancomycin, I think just empirically at that point in time, and blood cultures were turning negative. Day 8, CRS settled, and then day 9 developed ICANS. Poor handwriting, just a little bit off, not really confused, just kind of writing looked a bit like this. It's a different patient I was treating at the same time. You can see that we asked him to do a sentence every day. This is during ICANS, just period 1, I think she had, and then this is as she comes out of it. So you can see this is quite a sensitive measure of neurotoxicity. So he had something like this going on, and then kept on his dexamethasone. By day 12, things were settling. Dex was weaned, but by day 13, then he had some relapse and really dropped just started to get very muddled, confused. This was consistent at this point in time with grade 2 ICANS, and was increased. The Dex was increased to 10 QID. And was transferred to ICU. Just ongoing concern without prior to the weekend. From here, he had a fluctuating cognitive state and progressive steroid refractory ICANS. MRI brain was normal initially, but by day 21, he had been given truckloads of dexamethasone and developed hyponatremia, certain tolvaptan by endocrine, some clinical improvement, and then stepped down to the ward. We thought things were improving. On the Saturday following this, developed recurrent effusion, agitation, new urinary incontinence, back onto DEX, transferred back to ICU. And on day 30, brain now showed new bilateral hippocampal high T2 signal, and a CSF was positive for HHV6. Started for scarring for HHV6 and capsulitis and no improvement. Day 35, developed abdominal pain, discomfort, was intubated shortly afterwards, and CT showed a perforated sigmoid colon. He unfortunately passed away as a result of this perforation about day 40-ish post-CAR T, day 51 post-CAR T. And was unfortunately, in remission from his lymphoma by the looks of things. So it's just one of those things. We see these horrific toxicities with very effective treatments. And I think in terms of learning points here, steroid refractory ICANS may not always be ICANS. HHV6 infections, we've seen 2 of at King's from 100 patients. It's a recognized complication. And bowel perforation was ultimately a terminal event and probably related to, almost certainly related to steroid doses. So we have to be really careful. We got a lot of steroids to manage these patients. So just something to be aware of. I think I'm almost out of time, so I might just skip through the last case here. This is another patient with the same product, and I just last slide here just to show that essentially this is someone treated in the same way. This just shows you the neutropenia from the lymphodepletion. Initially, this is a typical sort of picture of neutropenia. Things start to recover, then the CARs get working, and you get this ICAT, a second drop in neutrophils. Most people by day 20 come back up. This lady stayed low. This is prolonged ICAT, and we really worry about these patients. They're very hard to manage. She had her normal fevers here, discharged here, and then started in daily G and came back in with a tazocin-resistant Klebsiella a day after discharge. She was then treated for that with gentamicin, some antibiotics, went home, and then had a GI bleed, dropped her HB to 40 with platelets of 10 about 2 weeks later, recovered from that, and eventually recovered her counts a month later, got home in a complete remission, and she was in remission at 6 months and going well, potentially cured. And she sent us a Christmas card right before we left. So it can go very well, but it can be very rocky. The summary I would say really is CAR T is here to stay, and we're expanding the indications all the time into the autoimmune space. The results in lupus have been outstanding from Germany. Multiple sclerosis, it's been trialed in now, solid cancers. But infections are a big problem we need to be aware of and continue to address. There is collaborative efforts underway between ourselves and our ID colleagues nationally. We're looking at formalizing prophylactic guidelines and management strategies, but definite need for more research. Happy to take any questions. So I think being able to tell CAR T levels reliably in blood would be really, really useful, to be honest with you. The assays are doable. It's actually pretty straightforward. You can do the research tool, but there's not a validated assay yet. I think that will come, and it will make our lives a lot easier, figuring out is there a huge load of CAR T cells in there or not. What I will say is that sometimes when this has been looked at in the research space, the expansion of CAR Ts and the CAR T level doesn't always correlate with degree of severity of CRS and ICANS. So it's difficult to know whether it will definitely help clinically, but useful to be able to monitor. And the other question was about what? Sorry, something about fungal.
Yeah, do you think it's a dynamic state that we can control during therapy, or do you think it's very much based on the first dose, essentially? So I said, could you use PCR to measure kind of the response? What's your opinion on that?
For autologous CAR, you have exponential takeoff, really, and different people will expand at different levels, but I think it's very hard to control. I think for allogeneic CAR, when you may be doing repeat dosing, which is something that's been tried and not so successfully yet, that might be something you could do. I think for autologists, it'll be more challenging, to be honest with you.